this is now recording, just so you know. Thank you. That's great.
So I learned. Okay. I learned this from my high school teacher. It's like how to memorize like the carpal bones. And the saying is, she looks too pretty, try to catch her. And so from the lateral to medial, it's scaphoid for she, lunate for looks, triquetral for two, and pisiform for pretty. And then from lateral to medial distal is for trapezium, it's tri, trapezoid, it's two, capitate, it's catch, and then hamate is her. And then I don't know if you guys can see at all, but it's just like this was the first one, and then that was the second one about try to catch her. So that's it.
Thank you. And yeah, you're anticipating where we're going with this. Today we're still yapping about bone tissue, but next week you get to like learn the chunks. Who all knows the bones already? Okay. Cool. Moving on. How was your Labor Day, by the way? Yeah? I kind of forgot that was Labor Day until the evening, and then, like, I went home and I smelled, like, barbecue around. I'm like, oh, right. Anyways, it's good. Okay. I have a video I want you to watch. It's longer than normally I show videos for, but it's interesting. It's on, actually, so a lot of videos so far have been, like, helpful animations to learn stuff. This one's people who are actually trying to regrow bones. Like, you'll just watch it and see. Online people, it's this one right here. This YouTube link. And we're going to go ahead and watch it. Also a little bit sorry about these PowerPoints. I had plans to put like comics and pretty things in them. Except this morning when I got up, I forgot that I had to like bring in dismembered chicken to lab, and then it took a while. It's for today's lab class, yeah. Whoa, sorry. You're looking at bones, but yes. And it stinks because it's been like hanging out with hydrochloric acid in my garage for a long time. I'm trying to clean it up as much as possible. Anyways. But I forgot about the chicken in my garage until this morning. Anyways. So yes. The slides are like bare bones. I'm hilarious. Alright. How's that on volume? Too loud? Too quiet?
As human.
Too loud? Too quiet? Emily? Too loud or too quiet? We're good? Okay. So, I realize some of this you might not know, but a lot of this you're like, oh yeah, obviously, I'm totally familiar with these cells.
To want to improve our health and minimize our suffering. Whatever life throws at us, whether it's cancer, diabetes, heart disease, or even broken bones, we want to try and get better. Now, I'm head of a biomaterials lab, and I'm really fascinated by the way that humans have used materials in really creative ways as a body over time. Take, for example, this beautiful blue nacre shell. This was actually used by the Mayans as an artificial tooth replacement. We're not quite sure why they did it. It's hard, it's durable, but it also had other very nice properties. In fact, when they put it into the jawbone, it could integrate into the jaw. And we know now with very sophisticated imaging technologies that part of that integration comes from the fact that this material is designed in a very specific way, has a beautiful chemistry, has a beautiful architecture. And I think in many ways we can sort of think of this use of a blue nacre shell and the Mayans as the first real application of the Bluetooth technology. But if we move on and think throughout history how people have used different materials in the body. Very often it's been physicians that have been quite creative. They've taken things off the shelf. One of my favourite examples is that of Sir Harold Ridley, who was a famous ophthalmologist, or at least became a famous ophthalmologist. And during World War II, what he would see would be pilots coming back from their missions, and he noticed that within their eyes they had shards of small bits of material lodged within the eye. But the very interesting thing about it was that material actually wasn't causing any inflammatory response. So he looked into this and he figured out that actually that material was little shards of plastic that were coming from the canopy of the Spitfires. And this led him to propose that material as a new material for intraocular lenses. It's called PMMA, and it's now used in millions of people every year and helps in preventing cataracts. And that example, I think, is a really nice one because it helps to remind us that in the early days, people often chose materials because they were bioinert. Their very purpose was to perform a mechanical function. You'd put them in the body and you wouldn't get an adverse response. And what I want to show you is that in regenerative medicine, we've really shifted away from that idea of taking a bioinert material. We're actually actively looking for materials that will be bioactive, that will interact with the body, and that furthermore, we can put in the body, they'll have their function, and then they'll dissolve away over time. If we look at this schematic, this is showing you what we think of as a typical tissue engineering approach. We have cells there, typically from the patient. We can put those onto a material, and we can make that material very complex if we want to. And we can then grow that up in the lab, or we can put it straight back into the patient. And this is an approach that's used all over the world, including in our lab. But one of the things that's really important when we're thinking about stem cells is that obviously stem cells can be many different things, and they want to be many different things. And so we want to make sure that the environment we put them into has enough information so that they can become the right sort of specialist tissue. And if we think about the different types of tissues that people are looking at regenerating all over the world, in all the different labs in the world, there's pretty much every tissue you can think of. And actually the structure of those tissues is quite different. And it's going to really depend on whether your patient has any underlying disease, other conditions, in terms of how you're going to regenerate your tissue. And you're going to need to think about the materials you're going to use really carefully, their biochemistry, their mechanics, and many other properties as well. Our tissues all have very different abilities to regenerate. And here we see poor Prometheus, who made a rather tricky career choice and was punished by the Greek gods. He was tied to a rock, and an eagle would come every day to eat his liver. But of course, his liver would regenerate every day. And so day after day, he was punished for eternity by the gods. And liver will regenerate in this very nice way. But actually, if we think of other tissues like cartilage, for example, even the simplest nick, and you're going to find it really difficult to regenerate your cartilage. So it's going to be very different from tissue to tissue. Now, bone is somewhere in between, and this is one of the tissues that we work on a lot in our lab. And bone's actually quite good at repairing. It has to be. We've probably all had fractures at some point or other. And one of the ways that you can think about repairing your fracture is this procedure here called an iliac crest harvest. And what the surgeon might do is take some bone from your iliac crest, which is just here, and then transplant that somewhere else in the body. And it actually works really well because it's your own bone and it's well vascularized, which means it's got a really good blood supply. The problem is there's only so much you can take. And also, when you do that operation, your patients might actually have significant pain at that defect site even 2 years after the operation. So what we were thinking is there's a tremendous need for bone repair, of course, but this iliac crest type approach really has a lot of limitations to it. And could we perhaps recreate the generation of bone within the body on demand and then be able to transplant it without these very, very painful after effects that you would have with the iliac crest harvest. And so this is what we did, and the way we did it was by coming back to this typical tissue engineering approach, but actually thinking about it rather differently. And we simplified it a lot. So we got rid of a lot of these steps. We got rid of the need to harvest cells from the patient. We got rid of the need to put in really fancy chemistries, and we got rid of the need to culture these scaffolds in the lab. And what we really focused on was our material system and making it quite simple. But because we used it in a really clever way, we were able to generate enormous amounts of bone using this approach. So we were using the body as really the catalyst to help us to make lots of new bone. And it's an approach that we called the in vivo bioreactor, and we were able to make enormous amounts of bone using this approach. And I'll talk you through this. So what we do is, in humans, we all have a layer of stem cells on the outside of our long bones. That layer is called the periosteum. And that layer is actually normally very, very tightly bound to the underlying bone. And it's got stem cells in it. Those stem cells are really important in the embryo when it develops. And they also sort of wake up if you have a fracture to help you with repairing the bone. So we take that periosteum layer and we developed a way to inject underneath it a liquid that then within 30 seconds would turn into quite a rigid gel and can actually lift the periosteum away from the bone. So it creates, in essence, an artificial cavity that is right next to both the bone, but also this really rich layer of stem cells. And we go in through a pinhole incision so that no other cells from the body can get in. And what happens is that that artificial in vivo bioreactor cavity can then lead to the proliferation of these stem cells, and they can form lots of new tissue. And then over time, you can harvest that tissue and use it elsewhere in the body. This is a histology slide of what we see when we do that. And essentially what we see is very large amounts of bone. So in this picture, you can see the middle of the leg, so the bone marrow. Then you can see the original bone. And you can see where that original bone finishes, and then just to the left of that is the new bone that's grown within that bioreactor cavity, and you can actually make it even larger. And that demarcation that you can see between the original bone and the new bone acts as a very slight point of weakness. So actually now the surgeon can come along, can harvest away that new bone, and the periosteum can grow back. And so you're left with the leg in the same sort of state as if you hadn't operated on it in the first place. So it's very, very low in terms of after pain compared to an iliac crest harvest. And you can grow different amounts of bone depending on how much gel you put in there. So it really is on-demand sort of procedure. Now, at the time that we did this, this received a lot of attention in the press because it was a really nice way of generating new bone. And we got many, many contacts from different people that were interested in using this. And I'm just going to tell you, sometimes those contacts are very strange, slightly unexpected, and they're very most interesting, let me put it that way. Contact that I had was actually from a team of American footballers that all wanted to have double thickness skulls made on their head. And so you do get these kind of contacts, and of course, being British and also growing up in France, I tend to be very blunt. And so I had to explain to them very nicely that in their particular case, there probably wasn't that much in there to protect in the first place. so this was our approach, and it was simple materials, but we thought about it carefully, and actually know that those cells in the body, in the embryo as they develop, can form different kind of tissue, cartilage. And so we developed a gel that was slightly different in nature, a slightly different chemistry, put it in there, and we were able to get 100% cartilage instead. And this approach works really well, I think, for pre-planned procedures, but it's something you do have to pre-plan. So for other kinds of operations, there's definitely a need for other scaffold-based approaches. And when you think about designing those other scaffolds, actually you need a really multidisciplinary team. And so our team has chemists, it has cell biologists, surgeons, physicists even, and those people all come together and we think really hard about designing the materials. But we want to make them have enough information that we can get the cells to do what we want, but not be so complex as to make it difficult to get to clinic. And so one of the things we think about a lot is really trying to understand the structure of the tissues in the body. And so if we think of bone, obviously my own favorite tissue, we zoom in, we can see, even if you don't know anything about bone structure, it's beautifully organized, really beautifully organized, with lots of blood vessels in there. And if we zoom in again, we see that the cells are actually surrounded by a 3D matrix of nanoscale fibers, and they give a lot of information to the cells. And if we zoom in again, Actually, in the case of bone, the matrix around the cells is beautifully organized at the nanoscale, and it's a hybrid material that's part organic, part inorganic. And that's led to a whole field, really, that has looked at developing materials that have this hybrid kind of structure. And so I'm showing here just two examples where we've made some materials that have that sort of structure. You can really tailor it. You can see here a very squidgy one, and now a material that's also this hybrid sort of material, but actually has remarkable toughness, and it's no longer brittle. And an inorganic material would normally be really brittle, and you wouldn't be able to have that sort of strength and toughness in it. One other thing I want to quickly mention is that many of the scaffolds we make are porous, and they have to be, because you want blood vessels to grow in there. But the pores are actually oftentimes much bigger than the cells, and so even though it's 3D, the cell might see it more as a slightly curved surface, and that's a little bit unnatural. And so one of the things you can think about doing is actually making scaffold with slightly different dimensions that might be able to surround your cells in 3D and give them a little bit more information. And there's a lot of work going on in both of these areas. Now, finally, I just want to talk a little bit about applying this sort of thing to cardiovascular disease, because this is a really big clinical problem. And one of the things that we know is that, unfortunately, if you have a heart attack, then that tissue can start to die, and your outcome may not be very good over time. And it would be really great, actually, if we could stop that dead tissue either from dying or help it to regenerate. And there's lots and lots of stem cell trials going on worldwide, and they use many different types of cells. But one common theme that seems to be coming out is that actually very often those cells will die once you've implanted them. And you can either put them into the heart or into the blood system, but either way, we don't seem to be able to get quite the right number of cells getting to the location we want them to, and being able to deliver the sort of beautiful cell regeneration that we would like to have to get good clinical outcomes. And so some of the things that we're thinking of, and many other people in the field are thinking of, are actually developing materials for that. But there's a difference here. We still need chemistry, we still need mechanics, we still need really interesting topography, and we still need really interesting ways to surround the cells. But now the cells also would probably quite like a material that's going to be able to be conductive, because the cells themselves will respond very well and will actually conduct signals between themselves. You can see them now beating synchronously on these materials, and that's a very, very exciting development that's going on. So just to wrap up, I'd like to actually say that being able to work in this sort of field, all of us that work in this field, that's not only super exciting science, but also has the potential to impact on patients, however big or small they are, is really a great privilege. And so for that, I'd like to thank all of you as well. Thank you.
Cool. Okay, I realized the last part wasn't bones, but thoughts? Can you imagine being the first patient approach for this? Like, okay, we need to, put some bone back. You've had some problems. Instead of doing it the normal way, let's inject saline solution under your periosteum and puff it out and see if we can grow new bone, and then cut that out and then put it someplace else. Would you go for it? Or you'd be like, yeah, I'll just deal with my agonizing pain. No. Okay, sorry, but other things to think about? I did like it, so I'm going to keep talking about stuff because I think it's an interesting video. Her point at the beginning that most stuff that people put in their bodies now, I mean, not like do it yourself, but that clinicians put in, you're trying to have it be inert, right? The reason fillings are made of what they are is because they just kind of sit there, right? But to actually regrow stuff, you need things that will interact nicely with the body. And yeah, bone is cool. Bone is a pretty good one to go for, because if you're saying like heart, they're working on it, but you've got to have all the capabilities for bone, right? You gotta have it interact and grow and all these things. But you also have to have it be electrically conductive, which is a whole other level of complexity. Concerns, questions, comments? All right. Okay. We saw this slide before. I'm going to keep yapping about it because why not? Um, these types of cells, the osteocytes, grown-up ones, osteoblasts forming bone, osteoclasts, they're big. They're the ones that break down bone. So yeah, it's hard on pictures. Osteoblasts are the ones that are squirting out that osteoid. This stuff isn't like, okay, so it's in bone, but it's not that brittle inorganic stuff, right, yet. It's the matrix. It's this basically it's collagen. All right, so it's collagen, and there are a bunch of proteins on this collagen that bind calcium. Right, so you've got this collagen. It's got a whole bunch of spots for calcium to stick to. Right, so you lay this down, and eventually you'll get calcium to stick to it, calcium phosphate. Osteoblasts divide. They're mitotic. They're doing their thing. We're good at these? Osteocytes are cells there in the bone that are no longer actively mitotic. They're not going to keep dividing, and they're built into the bone. They're surrounded by it. They're stuck. They act as sensors. So if it gets pushed, if it gets strained, if it gets twisted, they'll respond to mechanical stimuli. Did anybody here want to be an astronaut as a child? No? Nobody? Okay. You don't have to tell me, but did anybody, change what they were going to be when they grew up, every 2 weeks? No? Are you the people who, from, your infancy, are like, I'm going to be a vet, doctor, etc.? Yeah? Okay, great. I was every 2 weeks. I'm basically when people ask me the question of, what do you want to be when you grow up? I interpreted it as, what do you want to be right now? And so I'd be like, astronaut, explorer, whatever, photographer, who knows? Okay, but astronauts, when they go to space, you might have noticed that the force of gravity is interacting on them much less, right? And that's a problem because our little osteocyte buddies, they're responding to the force on bones. And if there's not a lot of just push, say the weight of gravity is crushing you down, you lose so much bone density. It is a serious problem. And if we're ever going to colonize Pluto or whatever, we're going to have to figure this out. Because people lose bone mass really fast when they're weightless. It's bad enough if you just don't use a limb for a while. Anybody had a cast on? Did you, I don't know, just tell me more. Cast on your arm? For a couple weeks, months? Yeah, when it came off, any noticeable difference between your two arms? Yeah, that's why you're didn't see the sun. Anything about size or strength? Yeah. So there's obviously muscle atrophy, but bone also will lose a lot of its oomph. And you can get back, right? But it's scary if people are if all of them is doing this, right? So if they're weightless for a while, they can lose bone mass so fast. It's scary. So that's why you'll see in I don't know if you guys follow NASA, but if you do, you'll see that astronauts spend a lot of time exercising. Which at first you're you're in space, do other things. Don't be, this is not the time to exercise. This is time to look at other things. They're spending that much time exercising because they're worried about coming back to Earth and crumpling, right? You don't want that to happen. So yeah, so these osteocytes are inside the bone. They're sensing strain. They're chilling there. They're going to communicate to both the osteoblasts, which are these bone-forming ones, and they're going to communicate to osteoclasts, the ones that destroy it, right? So they'll kind of let both of them know what's going on. Yeah? Concerns about this? Great. Osteoclasts, they're definitely bone. They're bone cells. They're from the same heritage, from the same embryonic stem cells that grow up to become macrophages. So macrophages are these big cells that go around chewing on things, right? Osteoclasts are basically their siblings. They've got the same, the stem cells were the same and they took different paths, but the nom 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 idea is the same for both of them. So these are big. So like macrophages are big. Osteoclasts are also really pretty big. I know when we talk about tissue, I was yapping about like the only time you really see multinucleated cells are in muscles. These guys are also multinucleated. But whereas like skeletal muscle, you'll see them over and over and over again. Osteoclasts, bone isn't just osteoclasts. They've got ruffled borders. It's not a great picture here. This little edge here, it's got a lot of surface area on it. So you've got all the surface area and they kind of just like glom on to the bone. And yeah, they end up breaking down bone by secreting, we'll see it later, by secreting some enzymes that chews it up. Everyone's with me here? Great. We saw this, but I looked at my notes, and I don't think I actually explained it. I just assumed that this made sense. We'll look at it microscopically really quickly, okay? Compact bone, lamellar bone, that's the kind of bone you're seeing if you're like holding a bone, right, on the outside of the skull, right, it looks smooth. It feels reasonably smooth, but not perfectly smooth. It feels a little bit rough. It's got osteons, a bunch of little canals, and then a bunch of lamella. So here's our picture. Okay, this is the periosteum out here on the edge, right? And then this whole thing is bone up there, only a little bit that we're looking at. Got nerves, blood vessels. You've got this nice circular structure. And this is all set up by what's called osteons. It's just a structural unit, okay, of compact bone. We're not worried about spongy bone right now. Compact bone. It looks like a tube. They act like little tiny pillars, like you know how in a building you'd have a bunch of pillars holding up, say, the ceiling, right? These pillars are parallel to the long axis of the bone. So if the bone's going this way, they're parallel to that, right? They're in the same orientation. What's interesting, I don't know I hope you can see it. Can you see the way the stripes are going? They're going different ways. The collagen, okay, so osteon cylinder, it's made up of collagen fibers running in different directions, and then it's going to get calcified. So you've got these collagen fibers going in different ways, which means it doesn't all shatter along the same plane, right? So like that's the problem if you're building like blocks, just stacking blocks up and up and up. You can put quite a bit of weight so long as it's straight down, right? But as soon as you bump it to the side, there's no support there, right? This is trying to prevent that. So you've got support going different directions. So the idea is supposed to withstand stress. Also, if it twists, it's not supposed to shatter. And then between these collagen fibers, you find all those, they're called bone salts. They're the inorganic portion of this. Yeah? Kind of a pretty organization. This thing right here is called the central canal, because it's central and it's like a canal, right? It's got fluid running through it. It's got blood vessels. And yeah, so this core of the osteon, you've got the central canal running through it. You've got perforating canals, because you need to be able to have things come out. I don't have a picture of them. There we go. We've got perforating canal, like, come on, computer. Like here-ish. So far, so good? Yep. And one more. Yep, okay. Perforating canals. The osteocytes are living in these little small cavities called lacuna. That's just their little cubby hole in bone that they're living in. And these little osteocytes get connected to each other by these little tiny, tiny canals that connect each other. So you've got the big central canal, you've got the large perforating canals, but then the osteocytes themselves in their little caves connect to the other to the other osteocytes. We should look at that picture again. So we've got a little lacuna right here, the osteocyte, and you see the little tiny things that look like scratches almost? They all get to talk to each other. Yeah? It was news to me when I was learning about bone, that bone wasn't just like a rock. It still gets to be a tissue. And yeah. And so the whole point of this is you got all these osteocytes, the osteon, get to talk to each other, and you also get to move nutrients and wastes around, right? Like bone is hard, it's solid, but it's not, well, but it's porous. It's got holes in it, small holes. And then, so you've got these osteons, right? These pillars. But anybody who's ever tried to, I don't know, stack spaghetti up, right? When you get the glob of spaghetti, you've got a whole bunch of spaghetti noodles that's still dry. You're holding it, right? You can pack them really tightly, right? But there still are those little tiny spaces between where each of the cylinders touch each other, right? It's not solid. You need to fill that, right? You can still have your canals running through this, but you want this whole thing to be solid. So you've got what's called interstitial, right? So it's between these osteons, interstitial lamellae. It fills the gaps in. All right, so it's not an osteon, but it's next to them. And you also have you also add some to help the bone stop twisting, but we don't care about that right now. So here's the basic picture. We see it right here. All these osteons. You can see we've got, well, okay, we do care about it. So all these osteons, right, these little tiny pillars, they're running long ways like this, right? The interstitial metal right here between them, and then the circumferal, the stuff around the circumference, right around here. So far, so good? Beautiful. All right, so that's our compact bone or lamellar bone. It's called lamellar bone because it's got lamellae. Sponge bone looks like a mess. Compared to that beautiful organization of the osteons are just like lined up, and like the video was saying, each level you go down deeper, it just, the organization stays beautiful. Sponge bone looks really disorganized, but it actually is organized along stress points. You don't have osteons in it. Okay, you don't have those little pillar things, but you do have osteocytes, right? They're connected to each other, and you've got this lamella stuff as well, right? So you have the same materials, you just don't have it organized the same way. And again, you've got blood supply to it. It's still alive. We can see it. We can see that different. Great. So I talk about nothing else, but bone gets both organic and inorganic components. Do you guys need a 5-minute break? Yeah? No? Oh, okay. Apparently not. We'll keep going. It's about time, though. If we need a break, this is time. I'll show you a dumb YouTube video about bones later, if we have time. It's a sing-along? It is a sing-along. It's creepy. Yeah. Okay, so bone, you get organic and inorganic components. The inorganic stuff, this isn't, so inorganic, it's not alive. It's not carbon, yeah. It doesn't have to be carbon-based, it's not alive, it's just solid and rock-like. It's mostly mineral salts. It's most of the weight of this stuff. It's heavy, all right? It's basically calcium phosphate crystals. So you've got calcium phosphate crystals. You had that collagen stuff, right? That was put down, the osteoid that got put down, and now you just, that's the organic portion. But the inorganic portion is you just throw calcium phosphate at this, and it crystallizes. It's really hard, right? It's going to resist compression, right? So compression is when you're like squashing like this, right? So like if you jump and land, your bones don't crumple. They shouldn't. They really, really shouldn't, right? Their compressive force is really pretty good. They also resist tension, which is like pulling, right? So if you're like doing a pull-up or just like hanging, right? Your bones shouldn't stretch, and they shouldn't break long ways. Bone is as good as steel at handling tension. Like weight by weight, bone is as good as steel at tension. It's half as good as steel at compression, but that's still not bad because this stuff is really light. And it like responds to forces and grows back itself. It is an amazing material. So the inorganic compounds, pretty straightforward. It's just basically mineral salts. The organic compounds there's a lot going on. So you've got all the cells that you need, right? You've got bone lining cells, you've got osteoclasts. You also have osteoid, which is this collagen stuff that's put down. Osteoid's about a third of the bone matrix. It's a lot of it. It's basically collagen. It's basically collagen that's had some funky things happen to it. So we've got these organic compounds, this inorganic component, the organic component, and there we go. What's interesting to me is bones are full of what are called sacrificial bonds. So you've got all these collagen molecules. Sorry, you've got all these, molecules. Collagen molecules all over the place that form these bonds with each other. And these ones are designed to break, to take some of that force off. So as a force is applied to a bone, it's expected that these are going to break in a certain way, right? Kind of like, I don't know, I don't know why I feel the need to go back to your childhood, but anybody ever do the egg drop thing? You know what I'm talking about? Where you're like, this egg, whoever can drop it from the highest thing and have it hit the ground and survive, right? Okay. Some of the very, very clever versions that do well, okay, so you don't just put the egg in, like, I don't know, a steel case, right, that touches it, because it'll still, like, bounce against it, right? But you have something that when it hits, it'll crumple but protect the egg. That's good news, right? These sacrificial bonds, they're designed to break, so if the force is applied, they'll break, but they'll take some of that oomph away, and you can protect a bunch. They also can stretch. And the bones and these bonds will reform. Great. Okay, so now we have bone. Now we need to control its growth or its resorption. What's driving this? Or better question, when do you see a big growth spurt in most kids? Not counting infancy, but after infancy, about what age are you expecting they suddenly get way taller? About 12, right? You're like, something's going to change, right? Okay. With that, any guess what's driving these changes? Say what? Hormones, right? You're like, this is the answer for anything involving puberty. You're like, yes, hormones. Okay. Hormones aren't something that just turn on at puberty. Like, they're hanging out with you since forever. It's just there are some dramatic changes, hormonal changes that do happen at puberty. But hormones are going to regulate bone growth throughout your life. So growth hormone is going to be encouraging bone growth during infancy and early childhood. It's going to, that growth plate in those bones, right, that cartilaginous bit that you can grow and then have your bone grow bigger, that pays attention to growth hormone. Thyroid hormones boss around growth hormones. So the thyroid hormone impacts growth hormone, which impacts this whole thing. Testosterone and estrogen both are going to play a role in hormonal control of bone growth. And then if any of these get too much or too little, you can have some problems, right? Just from what you know about other things, after menopause, do women have more estrogen or less estrogen typically? Less typically, right? Anybody know about when osteoporosis starts to be a problem, typically? Before or after menopause? Yeah, the sudden lack of estrogen causes a problem with how bone density is regulated. It can be a problem, which is one of the reasons why osteoporosis can happen to both males or females, but it's way more likely in females because you suddenly have this hormonal change that you weren't expecting. I mean, you were expecting it, but that the bone didn't handle well. So, do people see that yet? I asked a question, sorry. If you had to guess about what percentage of bone you're going to chew away in a week, about what percentage of your bone do you think you get rid of? You personally. You saw the number. Okay, sorry. People paying attention. Anybody not see the number? Does everybody see it? Take a wild guess. 1%? Is that really high? Like, that's a lot. 50%? I mean, like, pretty one guess. 5? Yeah, okay, yes, that's about where you're at. Which, I should, yeah, you were on it. You didn't see it, you just guessed this intuitive sense? Not bad. You're going to get rid of about 5 to 7% of your bone mass a week, which is huge, right? That's like a lot. And it goes at different rates, so your spongy bone, you basically completely replace your spongy bone about every 3.5 years. and your compact bone about every 10 years, right? So if you're looking at the exact physical piece of bone, you probably don't have that exact physical piece of bone that you had when you were 3, right? It's been replaced, it's been remodeled, and it just keeps doing this. So bone remodeling isn't just adding new bone on, it's also taking bone off. It's bone deposit and bone resorption. And osteoblasts and osteoclasts aren't fighting. I realize it's easy to kind of think of like, well, the noble osteoblasts trying to build bone, and the mean osteoclasts that are trying to break it up. But they're both doing their job, and they're doing it in conjunction with each other. And this is good to have happen, because there are some serious problems if it doesn't happen. I need pictures. I'm sorry, people. I realize these slides need pictures. The osteoclasts resorb. They're going to come along. They've got all this little fringed edge. They're going to move along the bone, and that fringed edge is going to touch tightly. It's going to keep other stuff out. It's going to touch tightly, and it secretes enzymes. These enzymes that lysosomal enzymes. So if you think of lysosome, you can think of cut, right? These enzymes and some protons that chew up matrix. And because it's so acidic, this calcium, the calcium salts, they go into solution. So you're basically dissolving the bone. So calcium salts in solution, and now that calcium can go to the bloodstream. Lots of blood throughout bones. Calcium can get picked up by the bloodstream and get moved around. This is good. This is good. The osteoclasts, as they're going along chewing up bones, they're gonna take care of dead osteocytes. They're gonna chew them up as well. As they break stuff down, they're going to just release it with interstitial fluid, which the blood will pick up. The osteoclasts do their job. Once they're done, they have controlled cell death, it's apoptosis, and the cycle continues. To turn the osteoclast on, you're worried about, you need something called PTH, parathyroid hormone. Your immune cells play a role too, but the opposite, but it's working in conjunction with this, is putting bone down, depositing new bone matrix, and then you can calcify it. So a lot of things will trigger this. So to trigger the reabsorption, to trigger osteoclasts, you're expecting PTH. You're expecting parathyroid hormone to be like, hey, break it down. To trigger bone deposit, you're expecting lots of things. Yeah. Have you ever been told, like, you should exercise to build healthy bones? You should. One of the signals for building more bone is stress on the bones. So mechanical signals, like as stress happens on them, bone deposits happen. If there's a lot of calcium and phosphate in the blood, that helps trigger this as well, right? You have the stuff to do it. If you don't have calcium or phosphate in the blood, you don't want to build new bones. You want to pull calcium out of the bones to get back into the blood. If you've got matrix there on the bone that doesn't have calcium yet, that triggers bone growth too. It's like, hey, we should fill this up. Yeah, you need both calcium and phosphate. You've got two different control loops working for this. Basically, hormonal controls, and then response to stress. So the hormonal controls, it's this negative feedback loop that's controlling the blood calcium level. calcium's all over the place in the body, right? You need calcium to build healthy bones, but calcium's doing tons of stuff. It's doing nerve transmission, like if you don't have calcium, nerve transmission will fail. It won't work. It's going to also be crucial for muscle contractions. Again, like, you gotta have calcium. For blood to coagulate, for blood to, like, glom up on itself, you need it. For cells to divide, you need calcium. For glands to secrete things, you often need calcium. Like, you gotta have calcium. You have, depending on how big you are, 12 to 1,400 grams of calcium. 99% of your calcium in your body is found in your bones. You have plenty of calcium in your bones, like lots and lots and lots of it. If your body ever needs calcium, it's like, hey, bones. And your bones will get rid of calcium to put into your blood. Alright? Your bones are an excellent reservoir of calcium. To absorb calcium back from, like, food, you need to have vitamin D, just for the record. Like, if you're, I don't know, eating eggshells plain, lots of calcium's in eggshells. I'm not recommending you eat eggshells plain, but eating eggshells plain, but you don't have any vitamin D in you, you can't actually use the calcium. Which is incidentally, anybody know what the main type of vitamin they put back in, say, whole milk? You seen it? Yeah, they add vitamin D to it. It's not just because, like, vitamin D is good for you. It's because if you're going to try to absorb calcium, you need vitamin D. Yeah. We're good? So that's the hormonal control idea. Okay. Got hormonal controls, response to mechanical stress. The hormonal controls, it's this negative feedback loop. It's a negative feedback loop that worries about parathyroid hormone, and calcitonin. Parathyroid hormone, produced by the parathyroid, more or less where we're looking for with parathyroid: head, neck, shoulders, hips, feet. Where are we expecting this thing? Yeah, about here-ish. Low blood calcium levels. If you've got low blood calcium levels, you produce PTH. Okay, so if you have low blood calcium levels, do you want to build bone or destroy bone? Low blood calcium. You want to destroy it, right? So if you've got low calcium in the blood, you're like, I need more. Where could I find some? Right? So parathyroid hormone encourages osteoclasts to liberate calcium, right? Encourage osteoclasts to go along, chew off bone bits, and release calcium, right? So PTH encourages osteoclasts. Once calcium hits the blood, it'll raise the calcium levels, right? Parathyroid hormone responds to calcium levels, so if the calcium levels are high enough in the blood, parathyroid hormone kind of chills. So you're basically, the on is low calcium levels, but if you've got high enough calcium levels in the blood, you don't worry about making this stuff. When parathyroid hormone's around, it's going to encourage osteoclasts. With me there? Calcitonin, the thyroid gland produces it in response to high levels of blood calcium. So if blood calcium is really, really high, calcitonin is produced. It doesn't appear to actively stop osteoclasts, at least not in the normal range of what we normally have, but really high doses, it can drop blood calcium level. Basically, parathyroid hormone is the really big one. Parathyroid hormone turns on with low blood calcium and encourages osteoclasts. Yeah? Here's our beautiful picture. So you've got I stole this from your book because it's kind of cute. You got this nice calcium levels in your blood of about 10 milligrams per 100 milliliters, right? You want to keep it right there. If your blood calcium falls, oh no, it encourages your parathyroid to produce parathyroid hormone, which is going to make the osteoclast leap into heroic action, chew up bone, and it brings this back up to where you want it. Yeah. So that's the hormonal idea. The hormonal idea, basically, parathyroid hormone is driving this. The mechanical stress idea, excuse me, I don't have the plague, I just apparently can't swallow appropriately. I used to never say this, but now I feel like if I sneeze or cough, I have to be like, I think I'm healthy. I hope. Okay. Dr. Cowgill's presentation last February or whatever, she was talking about this, right? They're like, if you're a tennis player and you keep using a certain bone over and over and over, it respawns, right? So bones get stressed if either there's weight applied or if muscles pull on them. Both of those things stress bone. They respond to the stress and they remodel the way that makes most sense for them to grow. And you can do fancy math on it. And you can have the way the load hits. Okay, briefly. The push and pull on the opposite side of this bone here, in the middle, cancel each other out. So it can be a lot lighter or less strong there, because if the push and pull cancel each other out, you don't need it to be super, super strong. Places where there's a lot of tension or compression, you want it to be stronger, right? Which is one of the reasons, like, sometimes when people are hurt or something goes wrong, they end up walking funny for a while. That's not the technical term, but they walk like off center. If you do that long enough, you can actually remodel your bones to respond to that, because the stresses are being put in different places, right? So like, don't go out of your way to get one shoe that's an inch higher than the other, right? Because if you do that for a long time, I don't know how you want to, but if you do, you'll end up having your bones grow differently. Questions, comments? Okay? So, take-home message so far, bones respond to hormones, and they respond to mechanical stress. Bone disorders, the three major types are things that, all bone disorders are basically something's wrong between how much bone you're putting out and how much bone you're chewing up. They come in three big flavors. This one is really kind of sad. It's called rickets. Well, rickets is a version of it. Osteomalacia. The bones aren't mineralized properly. So you've got the osteoid. You've got the collagen part. The collagen part is fine. That beautiful fiber part is fine. But you don't have enough calcium salts to hit it. What that means is your bones are squishy, right? Because you've got the structure for it, you've got the collagen for it, you just don't have it hard. This can happen to anybody. In kids, it's called rickets. Typically, it's a vitamin D deficiency. Sometimes it's a problem with not having enough dietary calcium. But the problem is, the bones are there, but they're soft. So upon weight bearing, they bow out. It also hurts. Make sure children get enough calcium and vitamin D, right? It's a rough deal. But this problem can happen to anybody if you don't have the inorganic part, right? We're solved on this? Yeah. This one, it's a problem, osteomalacia, but it's usually fairly easily treatable, right? You're like, the problem is You're not depositing calcium salts. Maybe we should give you some calcium salts. Oh, sneaky question. This is a problem because mineral salts aren't being deposited. Why would vitamin D deficiency maybe cause this? It's not a problem if there's not vitamin D in the bones. Bones don't need vitamin D living in the bone. You're not absorbing the calcium, yeah. Great. Okay. The next, well, the really big one that we're worried about is osteoporosis. It's a whole group of diseases, but basically, it's a catch-all term for, you know what? The rate that the bone's being resorbed is a much higher rate than the bones being deposited. Bones now are, so the matrix is fine, but the bone mass declines. Spine and femur, actually, are really susceptible to this. People will end up fracturing their hips. They'll end up, if you ever see little old ladies, or anybody, but they've got like a little hunchback, what's happened, I should draw this, sorry, I'm going to just act out quick. Vertebral discs, right, a whole bunch of them, I'll show you here. In osteoporosis, it can collapse, and so it breaks, and so they've collapsed a bunch of their discs, and now, I'll show you the video, and now it bows out. It's kind of a rough deal. We're watching this video, online people, and everybody. What? I know. What? We might not have time for the Bone sing-along song. If we don't, we'll watch it on Thursday. Is this too loud? Sorry, I don't know.
The skeleton is made up of bones, which provide support and shape to the body. They protect soft internal organs, such as the brain and heart, from injury. Together with muscles, strong bones enable the body to move freely. Bones have a solid outer surface called compact bone. The inner bone is called spongy bone because it is less dense than compact bone and has many small holes like a sponge. Bones contain cells called osteoclasts that break down bone tissue. Other cells, called osteoblasts, make new bone tissue using minerals such as calcium and phosphate from the blood. Hormones such as estrogen, growth hormone, and testosterone help keep the number and activity of osteoblasts higher than osteoclasts so that more bone is made than removed. Physical forces and pressure during exercise also help bones to grow stronger and denser. These processes allow bones to grow strong in children and young adults. People have their strongest, most dense bones, called peak bone mass, in their 30s. After this age, osteoclasts gradually remove more bone than the osteoblasts make. Osteoporosis is a condition that leads to weakened bones, causing them to break more easily. Healthy bone is dense enough to support and protect the body, and to handle the stresses of movement and minor injuries. However, people with osteoporosis have abnormally thin bones with larger holes in the spongy bone. There are two types of osteoporosis. Primary osteoporosis is usually related to older age, as well as a reduced amount of estrogen in women. Secondary osteoporosis affects both children and adults. It is related to other diseases or conditions, such as cancer, hormone problems, or use of certain medications. A person has a greater risk for either type of osteoporosis if they don't develop enough bone mass when they're growing from childhood to adulthood. Risk factors that can lead to low peak bone mass include a family history of osteoporosis, being white or Asian, being female, a poor diet, certain medications such as steroids or certain seizure medicines, lack of physical activity and weight-bearing exercise, and lifestyle behaviors such as smoking and drinking too much alcohol. A person also has a greater risk for either type of osteoporosis if they have an abnormal amount of bone loss after age 30. Some bone loss is normal after this age. However, a person with the same risk factors for low peak bone mass can be more likely to get osteoporosis as they age. Increased bone loss is also common in women after the time of a woman's last period, called menopause. After menopause, a woman's ovaries stop making the hormone estrogen. With the drop in hormones, bone-removing cells, called osteoclasts, are more active than the bone-making cells, called osteoblasts. Bones may break or fracture easily because they're unable to withstand the physical strain and pressure from even normal activities. Common fracture locations in people with osteoporosis include the wrists, spine, and hips. Building strong, healthy bones through a diet rich in calcium and vitamins and getting regular exercise can help prevent as well as treat osteoporosis. Common medications for osteoporosis.
Okay. You don't care about the common medications yet, do you? All right. The idea is pretty clear, right? That balance is not there between bone removal and bone deposit. And you can see when you look at the pictures, I made it big, so big, and you actually can't even see the tag. That one's normal. That one's got osteoporosis. It looks kind of rough. Risk factors, same as was shown there. Testosterone is somewhat protective against this, right? Treating osteoporosis, you're trying to do calcium or vitamin D supplements or weight-bearing exercise. The weight-bearing exercise is scary, right? Because you don't want to actually have people break their bones. Like, do weight-bearing exercises, but really don't fracture these, so careful. Hormone replacement therapy people are working on. It can slow down this. It can't actually reverse it, at least not that we've seen so far. And the tricky part with a lot of these treatments are the side effects. So hormone replacement therapy can slow this down, but it then increases people's risk for certain kinds of cancer and for stroke and for some heart disease. So you have to weigh some risks. Bisophosphates have a similar problem in that you're basically trying to shoot some of the osteoclasts, or trying to slow them down. It can help, but it can also make bones really, really brittle. So it can make the bone density look better, but if the osteoclasts who are supposed to be remodeling bones aren't doing it, you can end up with like bones that are like glass almost. Anyway, so yeah, it's not a very cheerful thing. But good news, maybe if you grow a bunch of bones from and harvest your own bones and put them back in you, our first video could help. Questions about this? And then the last set, we saw it just because it was cool or interesting before. Paget's disease, Pagetic bone is what it's called. It's not a problem that you're breaking down too much of it or you're depositing too much of it. It's just kind of random. bones can actually grow really fast. And you end up with pictures that look like these ones, where the bone mass is okay, and there's plenty of calcium, there's plenty of collagen. It's just got thrown down, kind of unorganized. We're not sure what causes this. It might be viral. People don't usually know they have it until they break some bone, because it does make bones behave oddly. Somebody goes in for an X-ray or whatever, and then the doc's like, huh. So yeah. It's not entirely sure what causes it. Calcitonin at some pretty high doses is used to try to treat it. Questions about that? Doing okay? Alright. That's what we've got. I'll see you in lab. Am I forgetting something? Should I be reminding you of something? No? Okay. Cool. We'll do our sing-along next time.